Hello, dear friends from Ninja Connect. The topic today is I'm going to present some challenging cases from Brazil. This was also shared in the CVC 2015. These are my disclosures. The first case is a female, 45 years old, asymptomatic, with some cosmetic complaints. This was the clinical presentation, reticular vein, something around 4 to 5 millimeters wide, with a normal SSV and connected to both to SSV and to a dilated perforator right in a medial calf. The first thought was to perform phone sclerotherapy. It was the easier and less invasive treatment. However, we did not do it because the risk of hyperpigmentation that everybody knows is higher in the phone sclerotherapy, and also because the fear of the progression of this phone sclero to the SSV causing phlebitis. So what we did was a 1470 diode laser, endovenous laser, using a 200 microns bare tip fiber with 100 joules per centimeter of energy. It was under local anesthesia. We started the ablation right in the fascia level. You can see right here, closing the perforator. You can see with the duplex scan, the perforator closed. And after that, we finished doing a phlebectomy. Case 2, male, 43 years old, with pain and ankle swelling, also with cosmetic complaints with this clinical presentation. The SSV was with a insufficiency from the popliteal, saphenous popliteal junction. The vein was close to the skin and with great caliber, very wide, something around 8 to 10 millimeters wide. This was a scan, the scan from top to bottom. You can see a very wide SSV. So what to fear doing a SSV at this size? Of course, everybody knows that EHIT is more common with larger veins. Also, the vein was too close from the skin, so we had a fear to burn the skin. Also, because we had to deliver a lot of energy, the nerve injury in this case is also a concern. And of course, because of the size of the vein, the treatment failure has to be considered. So what we did was thermal ablation under local anesthesia. You can see right here the performing a very just a great tumescent anesthesia. You can see right here in the SSV compartment, so protecting both the skin and nerve. This is a picture right after the thermal ablation. We call this the pearl sign, a very echogenic image with a shadow, acoustic shadow right here. And 10 days after the ablation, we can see right here the popliteal vein free and the junction occluded. Also, the occlusion of the SSV and the caliber was came down from 8 to 3 millimeters. So a very successful case. Performed thermal ablation in a very wide SSV with a great tumescent anesthesia. Case number 3 is a female, 56 years old, with pain and swelling, with previous GSV stripping. We can see the scan right here, a lot of superficial veins, and a very tortuous vein right in the saphenous compartment, and some length of the vein was straight, so we could perform thermal ablation in this case maybe, but the tortuous vein was very difficult to do it. So what to do if not treating all the length is related to more residual varicose veins and more residual symptoms. Von scleral is related to more recanalization after 12 months, because one thought was to perform von scleral in all the length of the vein. So what we did was a point of access right cranial to the SSV tortuosities. So in the part that the vein was straight, we did a puncture right there, a puncture, and then a laser fiber. This is the dilator, and then the introducer, and then after that the laser fiber was going through. You can see right here the laser fiber, the laser fiber going through, up and up to the higher position possible. And then tumescent anesthesia, also in the SSV compartment. Right there, you see the needle, and then the tumescent anesthesia, no secret. Then thermal ablation at that point to the lower point possible. So we're going to the lower point possible. After the thermal ablation performed in the cranial part, you can see right here it's all occluded, and then we have this missing. Of course, this is very tortuous for the thermal ablation. So after the thermal ablation, we did a distal puncture, also guided, also ultrasound guided, a distal puncture, and then von scleral, 2% polydocanal von scleral with the Shire method, 1:4 liquid air ratio. You can see right here in the deep venous system, the gastrocnemius vein filled with von. We are doing here a tiptoe. It was under local anesthesia, so the patient was doing some tiptoe movement to wash the deep venous system. And here you can see the von. You can see the von in that tortuous vein in the SSV compartment. Okay, case number 4, female, 62 years old, cosmetic complaints, 2 previous phlebectomies, 2 previous varicose vein surgeries. You can see that after pressure, we see it vanishing, and then the little veins, the distal longectasias, was filling up, and it was causing some cosmetic complaints in this patient. So, scanning with duplex scan, we could see a perforator vein right under that cosmetic lesion. and a reticular vein right beneath the skin. So what to do in this case? Sclerotherapy in the telangiectasias without treating reticular vein, bad result. If we treat the reticular vein without treating this perforator, also we got bad result. Performing phlebectomy in this case was technically very hard to perform. Remember that she already did twice. And endovenous laser in the perforator, also technically very hard to perform. So, what about von scleral in reticular vein? It's a 2.6 millimeter wide reticular vein, but possible to perform von scleral. So what I did was 1% von scleral polydocanal. You can see right here the perforator occluded with the von scleral therapy. It was also guided through with ultrasound, and the result right after the von scleral therapy. You can see after pressure of the telangiectasia, nothing happened. And in the above video, you can see the telangiectasia filling up with blood. So it was a technically very hard case to perform, but we treat this with von scleral because what was the best choice at the moment. So this is the final result. We got a patient very satisfied. Last case, case number 5, a venous ulcer for 2 years with GSV insufficiency. The GSV diameter was 18 millimeters in the junction, 9 millimeters in the thigh, and 6 millimeters in the leg, with an open ulcer right here. So what to do? Thermal ablation below the knee with an open ulcer, von scleral in a 6 millimeter leg GSV, and 18 millimeters at the junction. Was hard to decide, but because laser, we have only one point of access, and we protect very hard this point of access from infection. And with prophylactic antibiotic, we did a thermal ablation below the knee to the junction. So the point of the access was right here in the malleolus. We protect the venous ulcer with a plastic cover, and I removed after just to show you that we are performing thermal ablation right under the venous ulcer. So this case this at the moment that we performed the surgery. 20 days after, the epithelialization very needed to see, and the cicatrization very quickly. After 45 days, after 70 days, 120 days. This is just a demonstration of endovenous laser ablation in a tributary that is possible to do under local anesthesia as well. With a 600 bare tip in a 1470 laser with 4 watts, traction 1.5 to 2 millimeters per second. And in this case, also most of the surgeons would choose to perform a phlebectomy, and of course there are a lot of other techniques, including von scleral, but I can say that this case is possible to perform with 1064 ND YAG laser and liquid sclerotherapy. This association can make this treatment very easily and less invasive with a quick recovery. This is some of our training courses in Brazil, both for transcutaneous laser and phone sclerotherapy. This is my contact email and also my phone number. You can contact me through WhatsApp. This is our website. Also, be comfortable to contact us through Angel Connect.